In the following certified educational activity, Doctors Michael Wexler and Jeffrey Chupp discuss how to identify, diagnose, and treat patients with severe asthma. They are joined by Krysztof, who offers his perspective as a patient with severe asthma.
Hello, I'm Dr. Michael Wexler from National Jewish Health in Denver, Colorado. Welcome to this educational activity on the evolving landscape of severe asthma management, selecting patients for novel treatment and improving adherence. Let's get started. Severe asthma has a significant impact on the quality of life of patients and their families due to excessive symptoms, frequent and life-threatening exacerbations, increased comorbidity burden, and the high pharmacologic treatment requirements. Although estimates vary, about 5 to 10% of patients with asthma are considered to have severe disease, despite maximum standard therapy with inhaled medications. Many of these patients are dependent on oral corticosteroids, which can be associated with serious side effects when used long-term. However, it should be noted that severe asthma and uncontrolled asthma aren't the same thing. They overlap. Mild or moderate asthma can become uncontrolled if patients aren't taking their medications adherently, or if they're using their inhalers incorrectly. Even in patients with severe asthma and difficult symptoms, studies have shown that about a third of patients are taking less than 50% of their prescribed doses. So it's important to first address any issues that may be modifiable that are affecting a patient's level of control. Even when symptom control is good, patients' future risk of exacerbation should be assessed. Risk factors, other than those already mentioned above, include a history of one or more exacerbations in the prior year, low lung function, a smoking history, and blood eosinophilia. Any comorbidities that could contribute to symptom burden and poor quality of life should also be part of a patient's assessment. In recent years, novel research and clinical studies have provided new information regarding severe asthma phenotyping, endotyping, and new treatment options. We've come to realize that the identification of the patient's specific inflammatory phenotype, or the endotype, is important not only for research purposes, but also to implement a successful treatment plan. Type 2 inflammation describes an inflammatory pathway involving a subpopulation of CD4 positive T cells, known as Th2 cells, that release IL-4, IL-5, and IL-13, and stimulate type 2 immunity, which is characterized by high IgE titers, high levels of blood eosinophils, and high levels of oxalic nitric oxide. Type 2 innate lymphoid cells, or ILC2s, have also become increasingly recognized as key controllers of type 2 inflammation. So the production of type 2 cytokines, whether by Th2 cells or ILC2 cells, initiates and amplifies airway inflammation through activation of eosinophils, B cells, mast cells, macrophages, fibroblasts, and epithelial cells. With our growing understanding of the pathways of type 2 inflammation, multiple potential therapeutic targets have been identified, including those that involve IgE, IL-4, IL-5, and IL-13. The most convincing evidence for the role of type 2 inflammation in asthma exacerbation, however, comes from the effects of its suppression by type 2-directed therapies. These type 2-directed therapies include the anti-Ig agent Mepolizumab, the anti-IL-5 agents Mepolizumab and Remediable, the anti-IL-5 receptor agent Benralizumab, and the anti-IL-4 receptor alpha agent Dupilumab. When we come back, I'll be joined by Dr. Jeffrey Chupp, an asthma expert who will lend his expertise to a discussion of how to approach the evaluation of disease severity in patients with asthma, the use of type 2-directed biologic therapies for patients with severe asthma, and the importance of multidisciplinary collaboration and patient-provider communication in caring for patients with severe asthma. So stay tuned, and we'll be right back. Welcome back. Joining me today is Dr. Jeffrey Chupp, who's the director of the Yale Center for Asthma and Airway Disease at the Yale School of Medicine in New Haven, Connecticut. Please welcome Dr. Chupp. Jeff, so great to have you here. Welcome.
Hi, Michael. Great to be here.
So Jeff, asthma is a huge problem, and severe asthma in particular. So what steps should be taken when assessing a patient's level of asthma control? And what role should primary care take? When should a primary care specialist refer the patient to a pulmonologist or to an allergist?
Well, I think in the current era, we define control for asthma in two different main domains. One has to do with the patient's symptoms and their level of control during the day and at night and with activities, and the other relates to exacerbations of disease that require systemic steroids, which is something we obviously want to avoid. So if patients have poor disease control or they're exacerbating frequently, which is usually more than once a year, requiring systemic steroids, we consider them poorly controlled. Any patient who is not controlled on standard doses of inhaled medications or is exacerbating frequently should be referred to a specialist.
So how do you define severe asthma, and how do some of the governing bodies like the American Thoracic Society or the European Respiratory Society define severe asthma?
Well, the definition has been evolving over the last few decades, but recently the European Respiratory Society and American Thoracic Society has released some guidelines regarding what the current definition is, and that is patients who are on guideline-suggested high doses of medications, GINA, Global Initiative for Asthma Guideline 4-5 step therapy, and are controlled with that or remain uncontrolled despite those therapies, or patients who are requiring systemic steroids frequently, more than 50% of the year.
Yeah, so you're saying patients who have frequent exacerbations, people who continue to have symptoms despite standard therapies, or people who are on oral corticosteroids are really the more severe kinds of patients. So how do you evaluate for severe asthma? What are the criteria that you utilize? What kind of workup do you do for your patients to identify whether or not he or she has severe disease?
When a patient comes to our center with a diagnosis of severe asthma for an evaluation, there's really 4 things that we need to do. The first is we need to confirm the diagnosis, because we know that asthma symptoms are not necessarily specific for asthma, but could be caused by other diseases like cardiac disease, COPD, and other asthma-like variant diseases.
So you want to ask, so does the patient even have asthma?
Absolutely. Very
Okay,
important.
so you identify that the patient has asthma. How do you identify what other factors could be involved and identify that it's severe asthma?
So then, once we know the patient has asthma, we maximize their therapy and we make sure that aggravating factors are properly managed. These usually include allergies, reflux disease or GI-related disease, sinus disease as the main things. And then we also address adherence, so both compliance as well as inhaler technique. And we ensure patients are on the proper doses and types of medications to manage their asthma.
Okay, so you figure out that the person has asthma, you address their comorbidities, you address adherence. What next?
Well, once we do this, we then assess control, usually in a follow-up visit within a few months. And at that point in time, if the patient's controlled, then we're in pretty good shape and the patient can be chronically managed on those medications. If not, then we consider that patient uncontrolled, and then we consider additional phenotyping and possibly advanced therapies such as a biologic therapy or bronchothermoplasty.
I see. And so what kind of workup might you embark on? What kind of testing do you do to evaluate the patient who comes in? Do you do imaging? Do you do special kind of breathing tests? What do you do?
Well, I think that certainly in this day and age, we do high-resolution CT scans of these patients frequently, certainly as part of their initial workup to ensure we're not missing some other type of airway disease, such as bronchiectasis, that could be contributing to their symptoms or their poor control. Bronchoscopy is often pursued as well, I think especially at your institution. This is commonly done to ensure there's not some kind of occult infection or other disease lurking.
Do you do methacholine challenges on your patients?
In patients, usually that goes back into the is this asthma or not category to really understand if the patient's symptomatology, which can be mimicking asthma, is actually associated with airway hyperresponsiveness. So vocal cord dysfunction or reflux disease, pharyngeal reflux, these types of diseases can have a lot of symptoms that have been diagnosed by asthma, even for years by other physicians, and these patients may actually not have any associated airway hyperresponsiveness and have relatively normal lung function.
So do you do any kind of biomarker evaluation as part of your workup?
Yeah, absolutely. I think in this day and age, we've really shifted to looking at biologic biomarkers to understand the immunologic pathways that are active in a given patient. A decade or two ago, we would pursue allergy testing, usually through skin testing, and that's about it for blood testing. But now we do a total IgE, we do immunocap testing or skin testing to look for allergies, and then every patient has at least a CBC to evaluate for presence of eosinophils that could be associated with severe eosinophilic asthma.
And how about nitric oxide testing? Do you pursue that?
We do that. That helps us understand. It's really the only measure of inflammation that we have that we can do non-invasively in patients. So we do FeNO or nitric oxide measurement to understand if they have a type 2 inflammatory response in their airway that we can detect, recognizing that there's limitations to that test. And it hasn't been used prospectively to treat patients, to select patients for a therapy at this point in time.
So Jeff, you've mentioned a lot of different components of the workup and the evaluation of severe asthma, including making sure that it's asthma, evaluating for other contributing factors, and then identifying parts of the differential diagnosis and comorbidities. So can you summarize then, what does a referral center like yours offer in terms of the evaluation for severe asthma that may not necessarily be being done in a primary care practice?
Well, there's a number of differences between a community practice and coming to a referral center for management of your asthma. First of all, we have a multidisciplinary approach and team that addresses the patient's disease, and that includes a gastroenterologist with expertise in motility, ear, nose, and throat physician with expertise in rhinology and nasal polyposis, and allergists that have experience not only in the diagnosis and management of allergies and severe allergies, but also other types of immunodeficiency diseases. In addition, we do a deep dive into the patient's illness, and we don't really approach it from an empirical standpoint. We really want to understand both biologically and physiologically what's driving a patient's severity. And once we figure that out, if none of the standard therapies or advanced therapies that are available are good for the patient, then we can pursue novel investigational therapies that we have ongoing at our center.
So it sounds like you do an additional workup, you evaluate what type of asthma the patient has, and then you can target that appropriately. So what you've talked about is the importance of all the reasons to evaluate for poorly controlled asthma, and those include medication issues in terms of adherence, the comorbidities, lifestyle changes, I think you also alluded to a little bit. So let's talk a little bit about each one of those and dive in deeply into each of these important concepts. So let's first talk a little bit about some of the remediable causes of asthma control. Let's talk a little bit about medication adherence and inhaler technique. How big a problem is that?
Well, we know this is a significant problem with patients, and we know this not only because of our own personal experience, but it's really been reflected in the clinical trials with especially advanced therapies like biologics, where the control group of patients all improved, largely because they were being followed closely by research coordinators and had significant improvement in their inhaler technique and compliance, sometimes even being provided the medication during the trials. So we know this is significant, and studies have shown that really over half of patients don't fill their medications, 75% of the time.
So in the real world, patients aren't taking their medications as frequently as they're supposed to. And how about inhaler technique? How big a problem is that?
Well, we think this is a huge issue in our center, and so there's so many devices out there as well as medication types that patients, even if they try to do it well, often fail because they're not able to generate an adequate inspiratory flow, or they're spraying a propellant inhaler into their roof of your mouth or on their tongue and aren't using a spacer. So these are repairable things that really need to be addressed as part of maximizing medical therapy for these patients before you go into an advanced approach, because many patients will be able to achieve control of their disease simply by compliance and proper technique.
And education of these patients. And I think what we've both seen is that for the most part, a lot of physicians aren't spending the time, they don't have the time necessarily to teach their patients. So is that another thing that's offered in your center, is device management and education about inhaler technique?
Absolutely. We have a full-time pharmacist in our clinic that educates patients about inhaler technique, smoking cessation, including video visits where the patient will be at home and the pharmacist can interact with them and ensure that in their home environment they're using the medication properly.
And you also talked a little bit about comorbidities, reflux, and so what do you do in terms of addressing those components, and how do you address some of the key ones that you mentioned, including reflux disease, sinus disease? What are some of the key steps that you use in terms of management of those entities?
Well, with our gastroenterology partner, we really try to understand if a patient has some form of reflux disease that is not either asymptomatic or is not kind of picked up by standard tests. So they do specialized motility studies, including sometimes placing a probe into the distal esophagus to monitor for acid production for multiple days, rather than just doing a 12-hour, 24-hour pH probe. We do motility, looking at actually how the esophagus functions in terms of moving food, substances, and interact also with the ear, nose, and throat physician to see if there's evidence of laryngeal inflammation that could be a marker of reflux that is not being picked up and is intermittent but still contributing to severe disease.
Not to mention the chronic rhinosinusitis that often accompanies the severe asthma of those patients.
Right.
So let's say a patient's been determined to have severe asthma. You've gone through adherence, you've gone through inhaler technique, you've addressed comorbidities. They have step 5, GINA asthma, severe asthma. What then?
Well, then at this point, we will make sure that we've properly phenotyped the patient biologically, and we'll consider a advanced therapy for that patient, biologic therapy or possibly bronchial thermoplasty. So when we do that, we really try to characterize what immunologic pathways are active in that given patient so we can understand which biologic target we want to block.
So what you want to find out is what type of asthma does that patient have, and then you can treat that type of asthma appropriately based on specific biomarkers?
That's right.
So you do phenotyping, you do endotyping. These are relatively new terms. How do you distinguish between that terminology, phenotype versus endotype?
So a phenotype are the observable clinical characteristics in a patient that put them into a group with a style of clinical subtype that's based on the genetics and environment. In those patients, for example, we might in the past have called it exercise-induced asthma.
So that's one phenotype. So it's based on the trigger of their disease.
Right, and they had a particular clinical situation where their asthma was active. An endotype is a subtype of disease where you understand the pathway and how it's disturbed that drives the clinical disease. So for example, a simple one is cystic fibrosis, where we know it's a Mendelian trait disease where there's a specific genetic defect that causes the clinical picture. In asthma, it's much more complicated because there are really not that many genetic links that are quite so strong. It's a multi-gene disease. So in asthma, really the primary endotypes that we know at this point in time are really allergic disease, where we can really test for specific IgE production and allergies versus non-allergic disease. Some of these other subtypes that are emerging biologically, such as eosinophilic asthma, is still at this point mostly a phenotype, I would say, even though it's associated with a particular biomarker.
Okay, so what you're saying is that a phenotype is based on clinical characteristics, whether patients old or young, or black or white, or maybe their triggers, or there could be other aspects, the frequency of their exacerbations, whether they're obese or non-obese. These are all patient characteristics that are part of the phenotype, and the endotype reflects the underlying mechanism of disease. Now, there's two broad endotypes of asthma, type 2 and non-type 2 asthma. Can you talk a little bit about those two components, and how do you identify type 2 versus non-type 2, which I think both encompass allergic and eosinophilic to some extent as part of the type 2 disease. But maybe talk a little bit about type 2 versus non-type 2.
All right. Well, this is, as you know, a bit of a challenge still in our field, because I think we're still evolving in terms of how we define these things. But type 2 inflammatory responses, we know, are really identified either through an allergic response that you can detect with skin testing or specific IgE testing, or the presence of eosinophilic inflammation. And it's driven by both adaptive immune responses and innate immune responses. And if patients don't have those markers, then we would call that patient non-T2. Accessory types of biomarkers we look at that are associated with those responses would be an elevated exhaled nitric oxide level as well, since we know that that is largely dysregulated downstream of IL-13, which is a canonical type 2 cytokine.
So what are the key type 2 cytokines?
So the keys are IL-4, IL-5, and IL-13. And these are, both key in terms of driving the inflammatory response, both allergic and eosinophilic, but also are the targets of biologics.
So IL-4, 5, and 13 are generated from Th2 cells and innate lymphoid cells, and that's what generates those specific biomarkers from eosinophilic disease or mast cell-mediated disease. What about non-type 2 disease? What do we know about non-type 2 disease, and do we have any good biomarkers for non-type 2 disease?
Well, non-type 2 disease is really patients that aren't T2. So we don't have a biomarker, so we kind of diagnose them by exclusion, these patients. There's a lot of interest in neutrophils being a marker in the sputum of these patients, or these patients may be pauci-immune if you do sputum phenotyping. But at this point in time, there's no, I think, accepted biomarker to identify these patients.
So how can we identify those patients? And is it important to identify those non-type 2 patients? And what about people whose biomarkers may not be elevated because they're on oral corticosteroids? Where do they fit into this?
Well, these patients can sometimes be a challenge because it seems that they are steroid dependent, but you can't find the biomarker because the steroid is suppressing the inflammatory response and your ability to detect a biomarker. So in those patients, you have to either taper the prednisone or this corticosteroid that they're on and see if a biomarker emerges, or you treat them with an advanced therapy and then taper the corticosteroids and see if their disease remains controlled.
Yeah, in fact, I think the 2019 GINA guidelines say that if you're on oral corticosteroids, just assume that the person has type 2 disease. So we've identified different types. We've talked about phenotypes. We've talked about endotypes. What is the current strategy in terms of thinking about different biologic therapies? Which ones do we have at our disposal? And how do we identify who's a candidate for which specific therapy? And then maybe we can dive into each one of the biologics when we talk about some of the data behind them.
Sure. Well, now we have 5 biologic therapies that have been approved for the treatment of severe uncontrolled asthma. And interestingly, they all are against high T2 targets. So we have 3 drugs against the IL-5 pathway, 1 drug against the adaptive or IgE pathway, and 1 drug against the IL-13 pathway.
So, okay, so we have a potpourri, and these drugs have just been developed in the last few years. I mean, Mepolizumab was the first one that was approved that targets IgE. That was approved in 2003. But then, you know, really all the other ones that you mentioned, the anti-IL-5s, the anti-IL-4/13 therapies, those have just emerged since 2015. So they're novel strategies. So let's talk about each one of those in a bit more detail. Why don't we start off by talking a little bit about Mepolizumab and tell us when to consider that therapy, what is it indicated, how is it administered, and how effective is it?
So the biomarker or endotype requirement for selection of a patient for Mepolizumab is that they have to have a specific allergic immune response detectable either by specific IgE testing or by skin testing, and have a level in the serum of total IgE above 30 international units per ml. It has been effective in treating these patients who have severe uncontrolled allergic asthma.
So in the pivotal studies, how effective in the study by Bussey and by Soleil from the early 2000s, what were the major metrics of success, the markers of success with Mepolizumab?
So these studies, which were done, as you mentioned, in the over a decade ago, when we defined control and severity and exacerbation slightly differently, Mepolizumab showed improvement in asthma control and reduction in exacerbation rates. More recently, studies have been done, open label studies, but also controlled trials using more current definitions of exacerbations where Mepolizumab has been shown to reduce exacerbation rates that were systemic steroid requiring.
So you alluded to the fact that Mepolizumab is approved for patients with allergic asthma. Can you identify subgroups that may have a better response to Mepolizumab therapy than others?
Yeah, interestingly, in the Hanania study that was published a few years ago, they showed in a subgroup analysis that the higher the T2 biomarker, the more likely they would respond to Mepolizumab. And this included both eosinophils as well as FeNO.
Nice, and also I think periostin in that study as well.
Right.
And what about patients who have more severe disease versus less severe disease? How does Mepolizumab fare in that regard?
Right, so in that patient that's a Mepolizumab candidate who has severe clinical features of disease, the more severe the clinical features, the more likely the response as well. And that was in particular with hospitalizations. So patients requiring hospitalizations for severe allergic asthma, a more robust response to the drug.
So Mepolizumab, what you're saying is that Mepolizumab is more effective in patients who've got type 2 signal with eosinophils or nitric oxide, and patients who've got more severe disease, patients with more frequent hospitalizations. So what about the anti-IL-5 therapies? What can you tell me about Mepolizumab, Remediable, and Benralizumab?
So these are all targeting the IL-5 pathway, but not at the identical target. So Remediable and Mepolizumab are against soluble IL-5, whereas Benralizumab is against the IL-5 receptor.
And IL-5 is involved with?
So IL-5 is the canonical growth factor for eosinophils, and it basically causes eosinophils in the bone marrow to proliferate, enter the bloodstream, and then migrate into the airway.
So they're
and
involved
drive
in
inflammation. So they are really the primary growth factor for eosinophils. So when you target that pathway, you really have a dramatic effect on eosinophil function. And we know that eosinophils are really a key effector molecule probably in symptomatology, or certainly associated very strongly with severity of disease. So when we see that you can target that, when you target the eosinophil or the pathway, you tend to see significant improvement in clinical outcomes.
So what clinical outcomes do we see with administration of anti-IL-5 therapy?
So we see reductions in exacerbations. We see improvement in disease control or disease activity. And you can see improvement in lung function as well.
And what about patients who are on oral corticosteroids? Are there benefits for those patients? Do we see improvements in some of those metrics as well? Because those patients who are on oral corticosteroids, I mean, they're very challenging. They've been on corticosteroids for a long time. They get steroid-related side effects, cataracts, glaucoma, depression, weight gain, all these things. What are the benefits of some of the anti-IL-5 therapies with regard to patients who are on oral corticosteroids?
Right. These drugs have shown a reduction in systemic steroid requirements in patients who have, persistent levels of eosinophils above 150 cells per microliter or more in the blood on systemic steroids. These drugs will help improve the patient's systemic steroid dose and potentially get them off systemic steroids altogether.
And I believe despite coming to lower doses of corticosteroids, they also reduce exacerbations by about 50% compared to placebo. So tell us a little bit of the distinguishing features between the different anti-IL-5s. You mentioned that some target the ligand, some target the receptor. What's the importance of targeting the receptor versus the ligand of IL-5?
Right, so Benralizumab targets the IL-5 receptor in contrast to Mepolizumab and Remediable. And by doing that, there's two effects. Number one, in a sense, the drug is more anti-eosinophilic because the drug is directly binding to the receptor on the eosinophil and other cell types that express the receptor. But also, Benralizumab causes something called ADCC, so antibody-directed cellular cytotoxicity, which actually results in the apoptosis of the eosinophil. So its effects are fairly dramatic on reducing eosinophil counts very rapidly after dosing of the drug.
So patients who get these anti-IL-5 therapies, particularly Benralizumab, but all the anti-IL-5 therapies, they all experience a significant reduction in blood eosinophils?
That's right.
And what about tissue eosinophils? Are there effects as well on tissue eosinophils? Has that been demonstrated?
That has been demonstrated with Benralizumab in sputum primarily. So yes, both tissue eosinophils and blood eosinophils decrease.
And are these therapies more effective in people who have higher eosinophils or independent of eosinophil level? How do these drugs work in terms of the different patients that we may see?
So in the anti-IL-5 trials, patients were selected based on having an eosinophil count above usually 150 cells per microliter or 300 cells per microliter in the case of Benralizumab at the time of entry into the trial.
Okay, so how can we differentiate between these three different biologics? I think you've mentioned that all three of them, Mepolizumab, Remediable, Benralizumab, reduce exacerbations. They improve outcomes, improve lung function. So tell us, how do we distinguish between them? What are the key features of these different therapies?
Well, the main differences are related really to how they're dosed and the cutoffs that are used. There's no head-to-head trial, so it's really hard to know how they would perform against each other. But in terms of the way the trials were done and the approvals that have been given to each of the drug, we know that Mepolizumab, recently approved to age 6, it's given sub-Q every 4 weeks, and the eosinophil level that was used in the clinical trials was 150 cells at the time of entry into the trial, or 300 cells per microliter in the year prior. Remediable is age 18 and up. It's dosed IV, so it's become, I think, a little less popular just for practical reasons. And it's given every 4 weeks, and in the trials they use 400 eosinophils per microliter as the cutoff. And Benralizumab is approved down to age 12. It's provided sub-Q after a monthly load for 3 doses. It's given every 8 weeks. And the cutoff for those trials, it was 300 cells per microliter at the time of entry into the study.
Okay, so they're all indicated for patients with eosinophilic asthma, but unfortunately we don't have head-to-head studies at this point to help guide us to say one drug is better than another. So all of them are pretty effective in terms of management of patients with eosinophilic disease. So we've talked about the anti-IL-5s, we've talked about anti-IgE therapies. The latest biologic to emerge was the anti-IL-4, anti-IL-13 therapy. What can you tell us about dupilumab?
So dupilumab has been clinically available for about a year. It's a biologic drug as well, and it targets the IL-4 receptor alpha. And this receptor is what I like to call a promiscuous receptor. It is part of both the IL-4 and the IL-13 pathways. And so when you block it, you block both the IL-4 and the IL-13 pathway. Evidence of this in clinical trials was that we know that IL-4 is an important mediator of IgE production and class switching to IgE. So patients treated with dupilumab had reductions in their IgE levels. We know that IL-13 is a strong mediator of INOS, or inducible nitric oxide synthase. And so patients who were treated with dupilumab had reductions in their nitric oxide levels in the clinical trials. This was somewhat unique compared to some of the other drugs, this outcome.
But dupilumab's approved for patients with eosinophilic asthma. So what's the relationship between IL-4, IL-13, and the eosinophil?
That's right. So as we said, these patients with high T2 disease can have all these biomarkers elevated. And while dupilumab was shown to work in patients regardless of their biomarker in their phase 3 trials, it was also fairly clear that the patients with higher T2 signals responded better in subgroup analyses. And so the indication is really for eosinophilic disease.
So and that may be related to the fact that IL-4 and IL-13 play a role in maybe eosinophil trafficking into the tissue along with IL-5, and so maybe that's how it exerts its effect in patients with eosinophilic disease. So what are some of the outcomes, and how successful and effective is dupilumab in patients with severe asthma? What are some of the key metrics that you evaluated and that have been studied in the phase 3 studies?
Right. So similar to the other biologics, the key outcomes that were used in the dupilumab trials were exacerbation rates, disease activity, and lung function, which were all positive outcomes for dupilumab. So it showed reduction in exacerbation rates, significant improvement in lung function, and improvements in disease activity. Also, similar to Benralizumab and Mepolizumab, dupilumab showed that patients who were systemic steroid dependent, regardless of their eosinophil count at baseline, had significant improvements in their disease control and systemic steroid requirements, with approximately half of the patients coming off of systemic steroids altogether after about 6 months of treatment.
So that's with dupilumab. And dupilumab is administered at home, and it's administered every 2 weeks, right?
That's right.
So effective therapy, again, similar to the anti-IL-5s and anti-IG, reduces exacerbations, improves lung function, pretty good magnitude of improvement in lung function, and is able to facilitate corticosteroid withdrawal and reduction in exacerbations in patients on oral corticosteroids, particularly in people with type 2 disease, eosinophils, nitric oxide, and IG as biomarkers. So what about any biologic therapies that are in development now? So we've talked about ones that are approved, but what's coming down the pipeline for management of patients with severe asthma? What can we look forward to?
Well, it's interesting, as we've really evolved our understanding of the immunology, we've also started to shift the targets that we're approaching. So we're moving away from the just T2 pathway to what are considered to be kind of higher level cytokines that are driving the inflammatory response. So the one that we're anticipating is going to be in the clinic next is a drug called Tezepelumab. And target is TSLP, which is a cytokine, or what is also known as an alarmin, that's released by bronchial epithelium in the setting of inflammation.
Yeah, so thymic stromal lymphopoietin, or TSLP.
That's right.
So it's pretty proximal in the inflammatory pathway for type 2 inflammation. It may also play some role in non-type 2 inflammation. So by doing that, what are some of the effects that you may see?
So interestingly, it has effects on both the adaptive immune response and the innate immune response. And it appears in the early trials that it has similar effects on patients who have high T2 biomarkers as well as low T2 biomarkers. So reductions in exacerbation rates were similar when they looked at a eosinophil cutoff of below or above 250 cells per microliter.
Wow. So it seems like it's a therapy that's effective. It affects IL-4, IL-5, IL-13. It seems like it'll be effective in both type 2 and maybe some non-type 2 patients. We'll see. Where is that in development now?
That's in phase 3 right now.
Oh, good. So looking forward to seeing those results, and hopefully we'll have yet another therapy to add to our armamentarium. So what do you think the future holds for severe asthma management? Where do you think we'll be in the clinic in, 2 to 5 years?
Well, I think that, we're going to have probably at least one more biologic therapy available, many, maybe others. So, they will, I think the unmet need is still the low T2 disease. We don't know how to approach these patients, both from a subgroup or endotypic and biomarker evaluation standpoint, but also we don't have a lot of specific therapies for those patients. I think that, as you know, from studies that are about to start soon that are funded through the National Institute of Health, we're going to be using therapies that are potentially microbiome-based, dietary supplement or antioxidant-based, and other pathways that could be driving some of these additional phenotypes of disease. So I think it's an exciting time for patients and physicians who are in the severe asthma space, because we're, I think, evolving our understanding, and we're going to have a lot more to offer.
Yeah, this certainly is an exciting time. And with all these new therapies, it would be hard to expect primary care physicians to keep up to date. So circling back to how we talked about the importance of involving a specialist and the importance of a multidisciplinary collaboration, how can primary care clinicians and specialists help each other when managing patients with severe asthma?
Well, I think that key is communication and having a good access and good relationships with your specialists and your community physicians, because asthma is a chronic disease. It's often cared for both in the specialist and primary care realm, and so you really have to work together to make sure that the patients get what they need.
So do you encourage patients to share in decision making, and what about self-management plans? How do those get incorporated into the day-to-day management of our patients with severe asthma?
Well, I think this is evolving as well. We know that as-needed use of inhaled steroids is probably something that's coming down the pike for our patients with milder disease or moderate disease, where they don't need to be taking an inhaled steroid and long-acting beta agonist every day or multiple times a day. Their disease is mild enough that we can minimize their medication exposure and still have the level of control. These studies need to be done, and these patients still need to be seen and managed and frequently, and communicate with their physicians. So I think that all of these things will result in improved quality of life, and hopefully will minimize exacerbation risk, So again, as we started, if physicians are identifying patients who don't have adequate control or they're exacerbating, they really need to think about moving to educate the patient about that and refer them to a specialist.
Yeah, and so I think patient-clinician communication is key, identifying what the goals of treatment are and what the goals of treatment are for each patient. I think that needs to be individualized to some extent and incorporate those patient preferences in terms of their acute asthma management plans. And so, the buzzword of shared decision-making has been incorporated into our daily practices. And there, the focus is really on choice rather than change. So can you comment a little bit about that in terms of engaging patients in their decisions?
Well, I think that the more you engage patients in the decision, the more compliant they will become because they know they have control over their disease and their choices. So healthcare professionals have a duty to inform people about the benefits and harms of any proposed treatment that they have. And especially when we're talking about injectable drugs and home dosing and as needed use. And these things need to be discussed with the patient and a decision needs to be made together.
No, I agree. I think patient education is going to be key to success here for engagement with the patients, and so that patients understand why they're taking their medications, how to take their medications, and if we work with them, if we understand what the barriers are, I think we can have a significant impact in terms of preventing exacerbations, and we have to keep an open line of communication. So this has been a great discussion, Jeff. I think we've really talked about what severe asthma is. We've talked about the different types of severe asthma, the heterogeneity of severe asthma, and then all the new and novel different approaches that we really have now and that we're hopefully going to have in the future. So thanks so much for having this discussion with us today, Jeff. Great conversation.
Thank you for having me. Great being here.
When we come back, we'll be joined by a patient who will talk about his experience with severe asthma and the challenges of finding effective treatment. So stay tuned. Welcome back. Building on our previous discussion, Dr. Chupp and I will now be joined by a patient with severe asthma, and we'll take a closer look at some of the practical considerations when it comes to managing these patients. Please welcome Mr. Krysztof. Chris? Thank you so much for joining us.
Doctor, my pleasure, doctor. Thank you very much for having me.
Great to have you.
Thank you.
All right, Chris. So tell us a little bit about yourself. How old are you? Where are you from? What do you do for a living?
I'm almost 63 years old. I was born and raised in Poland. I came to the United States as a young adult. I'm a mechanical engineer. I design heating, ventilation, and conditioning systems.
Wow. And tell us now a little bit about your journey with asthma. When did it start? When were you diagnosed? Did you have asthma as a child?
No, I never had any symptoms that I would associate with asthma. I was getting regular colds and flus, but never anything like asthma. The first time it happened to me, it was on my daughter's wedding on May 12, 2012. It's easy to remember. And I had like very severe allergy-like symptoms, but I managed through the day. I had no other choice. It was my daughter's wedding. A few days later, I went to see a doctor. The X-ray was taken, and I was diagnosed with severe asthma.
So he did some breathing tests and said your lung function is low. What sort of symptoms were you having at the time?
Well, at that point, I was working in New York City, and walking one block in New York City was a problem for me. I had to stop in the middle of the block. I would have wheezing in my bronchi tubes. I would have attacks, heavy, severe attacks of cough that I could not stop, and that would lead to shortage of the breath. So it was really hard to function.
Were you a smoker? Any smoking history?
Very long time ago, but I stopped.
So you were diagnosed with asthma. Your doctor characterized it as adult onset asthma? How did he say, what type of asthma did you have?
He said this is severe asthma that has to be treated, and was treated with steroids.
So with oral corticosteroids?
Yes.
Like what? What therapy were you treated with?
What was the prednisone? We started with prednisone.
Okay, so you were treated with prednisone, and then were you able to come off of the prednisone?
No, never. The first doctor was treating me with a higher dosage and reducing them. That was causing very quick elapses of attacks, of the symptoms. And by the end of the first year of 2000, which was 2012, part of my lower left part of my lungs collapsed.
Really? So were you using inhalers at the time too? Were you using
Yes.
inhaled corticosteroids,
Yes,
bronchodilators?
It was inhalers and the steroids taken by mouth.
And did you have any allergies?
No. Year and a half later, I was tested for the allergies in New York City, and I was called like a special case who doesn't have any allergies to anything.
And did your doctor say you had any eosinophils? Have you heard that term before? Eosinophils are kind of white blood cell.
Well, the first time I heard about eosinophils was I heard from the doctor in New York City. This my second pulmonologist.
Okay, so tell us a little bit about that. How did that term come about?
Okay, so after my lungs collapsed, my family got very upset, and they found a doctor in New York City, and he performed bronchoscopy. He opened a collapsed lung, and from that moment on, he was treating me with regular dosage of steady steroids, and he told me that my problem is caused by high level of eosinophilic cells in my blood. What's the reason? He could not say. He said that the only known to him ways of controlling is the steroids.
So Jeff, how would you characterize Chris's asthma at that point?
Well, I think getting back to our earlier discussion, it sounds like this is a classic case of adult onset eosinophilic asthma. Without atopy or no allergic biomarkers were detected. You didn't have allergies by testing, but you did have severe asthma with elevated eosinophils. And clinically, it was a disease that was really steroid dependent. Every time they decreased the steroids, you developed shortness of breath and worsening. Did you have a history of nasal polyps at any point in time?
Yes, and I had them. Yes. In the matter of fact, the doctor, my allergy doctor who performed the test for the allergies, he said, you're perfectly free of allergies, but he said, you see, I have a head scan over here. Would you like to sit over there? And he performed a head scan, and after that, well, he used the word that you can only use in New York. He said that whatever he saw, it was horrible in my head. He never saw anything like that. It was a heavy, severe infection of my sinuses. There was no open ways. He showed me his scan compared to mine, and it was like day and night physically, white and black.
Did you ever require surgery for your sinus nasal polyps, or it got better once they got your disease under control?
I had, shortly after we discovered that the infection, and there was also significant growth of polyps, I found another doctor who performed the surgery.
It's a very classic history here of high T2 disease with adult onset nasal polyposis and eosinophilia, but no adaptive immune response, so the IgE response is negative.
Yeah, very, very interesting and classic kind of case. So tell us a little bit more about the journey and what treatment strategies you've been through since that time. Inhaled steroids, bronchodilators, oral steroids. Tell us about the interactions you've had with different healthcare providers.
There was a good doctor in New York City, who was treating me on the steady dosage of steroids and inhalers. And at some point, the doctor told me that we can do it. In order for me to function properly, I would have to stay on those steady dosage. But he advised me to take a trip to Denver, to National Jewish Health, and he mentioned there is some new developments in biologic medicine that might be available soon, and he advised me that Denver hospital is the best source of learning about it and getting there.
So you took a plane to Denver, and what happened next?
Well, I contacted a doctor in Denver. I sent him the email, and in 25 minutes, he responded. And he said, "I'm sorry that you suffered for such a long time. Could you come to Denver?" So I was over there very soon. And doctor explained to me again what is my issue, and that the new biologic medicine is just about to be available on the market, and I qualify for that. And it took a while before the medicine was available. Also, I went through the tempering process of steroids. I started that new biological medicine in spring of 2017. Since then, I was able to, my doctors were able to reduce the steroids to 0. And for the last 2 years, I don't take any steroids. And I function very well, I would say.
So, Chris, you've been through quite a journey, and you started off by having a lot of symptoms, starting even the day of your daughter's wedding. Tell us how asthma has interfered with your quality of life early on, and then how things have changed over the last couple of years.
Oh, the first stage, which was the stage from my daughter's wedding to the time that my lungs collapsed, it was horrible. I practically could not function. Then the second stage of my disease, when I was on steroids, I could function, but I was steroids dependent.
When you say you couldn't function, you were having what type of symptoms?
Well, I had a very heavy coughing attacks that I could not stop. That would lead me to shortage of breath. I barely could walk. That time I was working in New York City. Making 1 block in New York City was a challenge.
So you were on oral corticosteroids, you were on inhalers, you were having all sorts of symptoms. You really had severe asthma. And so then tell us about when you started biologic therapy. What happened then, and how did that go for you?
Well, other than become independent from steroids, I don't have any more symptoms. If I didn't know that I have that illness, I would not guess that I have. Right now, I'm exercising every morning. I'm skiing on pretty high elevations. I ice skate.
Wow. So you went from not being able to walk a block in New York to being able to ski downhill.
I know it sounds like a miracle, but it's a true story, yes.
Incredible.
It is incredible.
And how had your asthma impacted your family, your work, your social life, your quality of life?
Well, it's a day and night. It's from not being able to go out to do anything to the situation that I'm a very normal person. I would even say that I'm in very good shape right now.
Beforehand, did you have frequent visits with your physicians? Did you go to the emergency room, hospitals?
Well, I had to go for the bronchoscopy when my lungs collapsed, and yes, I had to be seen by the doctor when those things were elapsing.
So it really interfered with your daily living. Did you miss work?
Yes, of course, yes.
So you missed work.
It was miserable, let's put it this way.
It was miserable. And so now, since you started biologic therapy, it's now been a couple of years, how have things evolved?
It's a completely different situation. I'm the very healthy and active person. I don't have any symptoms of asthma, period.
So Jeff, tell me, how would you characterize his asthma control when his disease first manifests itself to now when he's on biologics?
Well, it sounds like you went from being very severe and not being able to walk and persistent shortness of breath even on systemic steroids to now being off systemic steroids, but literally having no symptoms at all, able to do heavy exertion and not require systemic steroids and have what I like to call remission level control.
Yeah, it sounds like he's truly in remission. And what about any of the other aspects of your disease? What about your sinus disease? Has that gotten any better as you've started biologic therapy?
I rinse my sinuses regularly, and I observe what's coming out of my sinuses. Since I switched to the biological medicine, they are clean.
Amazing. So what do you think the role of the patient should be when it comes to working with providers who are diagnosing and treating severe asthma?
The patient should learn about how his body reacts to medication, but also the communication between the patient and the doctor should be educational.
It sounds like you're a strong self-advocate. I mean, you had symptoms, you saw one lung doctor, you ended up going to another lung doctor, you ended up even going to Colorado to see a third doctor. So I think what you're highlighting is the importance to be a self-advocate for your care and to actually try to identify specialists who can help you for your specific problem. You've gone from doctor to doctor to find a specialist who can help you manage your specific type of asthma, and it took some time. It was a bit of a journey.
It was.
So from a practical perspective, how have things changed for you in terms of getting these biologic therapies? Any issues? They're different from the inhalers. They're a shot. Has that had any impact on your quality of life at all, or how's that been?
Oh, the one that I'm currently taking, I perform the injection myself at home. It's trouble-free. It's practically doesn't take any time of my time. It's like it's not happening. It's trouble-free.
Great. So do you have any advice or perspectives on some of these non-medical interventions, support groups, anything else to help manage your severe asthma?
Personally, I don't have opinion on it, no.
Okay.
No, the best advice would be to find yourself doctor you trust.
Okay. Jeff, any closing thoughts on Chris's care and on his severe asthma?
Well, I think this is a great example of how a patient self-advocates, seeks out the expertise they need, and it's a great story for severe asthma, which is for patients, which is if you're struggling and you have symptoms that you really don't have to live that way anymore. And if you're not getting what you need from the physicians you have, then seek out expertise at a center that specializes in severe asthma and get what you need, because many patients can have Chris's story too.
For sure.
Well, Jeff, Chris, thank you so much for joining us for this discussion today. It's been a terrific discussion about severe asthma, and Chris, you really are a testament to overcoming severe asthma with some of the novel therapies. So what we've learned today is that it's critical to identify patients with severe asthma and to recognize the heterogeneity of severe asthma. We now have targeted treatment options that can significantly reduce asthma exacerbations in patients with severe asthma. And these selected agents can also improve asthma-related quality of life, asthma control, and have significant impacts on pulmonary functions as well. We now have therapies that target interleukin-5, interleukin-4, interleukin-13, and these have been shown to significantly reduce oral steroid requirements in patients who chronically require oral corticosteroids while simultaneously improving asthma outcomes. We've also talked about how important it is to have effective collaboration between specialists and primary care providers, as well as the importance of communication between patients and their physicians in order to improve outcomes in patients with asthma. So thanks for joining us today. We hope you found this information useful and will be helpful for the management of your patients with severe asthma.
This activity has been jointly provided by National Jewish Health and PVI, Peer View Institute for Medical Education.